Welcome to the Canadian Concussion Center's webinar series, which is sponsored by LAUNA, which is the Laborers International Union of North America. My name is Leslie Rattan. Some of you will know that if you're return visitors, and I'm really pleased to be moderating our webinar series, which has been developed for people that have sustained concussions and are dealing with persistent symptoms, as well as for their friends, families, and healthcare providers. As you may know, the sessions are recurring every other week on Tuesday evenings at the same time. And just so that you know, the sessions are all recorded. So they are available on the Canadian Concussion Center's website. So you're always able to go back and view something if you miss something. They will be up shortly after they run live. So also just to orient you, you'll see at the bottom of your screen, there's a Q&A. If you have any questions, please type them there. So we're going to begin with a presentation for the first 30 minutes and then have a question and answer session. So you can enter those there. If you're having any technical difficulties, please enter those questions into the chat and Christian will help you out with that. Just quickly before I introduce our speaker, we're going to run just a quick poll. Christian, if you can just pull that up, it's always helpful for us to know who we have in the audience. So if you wouldn't mind just completing this one question and then we'll carry on. Okay, so for this evening's presentation, I'm really pleased to introduce Dr. Carmela Tartaglia. And Dr. Tartaglia is an associate professor at the University of Toronto and a cognitive behavioral neurologist at the UHN Memory Clinic, where she sees patients with neurodegenerative diseases and persistent symptoms of concussion. She's a scientist at the Tan Center for Research in Neurodegenerative Diseases, where she uses a multimodal approach for biomarker discovery to facilitate early detection of neurodegenerative diseases and diagnosis of persistent symptoms of concussion. The ultimate goal of her research programs is to develop biomarkers for early detection of disease so as to provide targeted, personalized treatments for her patients. She holds the Marion and Gerald Soloway Chair in Brain Injury and Concussion Research as well. And with that, I'm going to turn it over to Dr. Tartaglia.
Thank you, Leslie, and welcome everybody. So I will start. These are my disclosures. So let me just start by talking about the different types of brain injuries so that we can kind of like set the stage. We're going to be focused on concussion tonight, or another word for it is mild traumatic brain injury. And they don't actually mean the same thing, but they're often used interchangeably. And mild traumatic brain injury usually is kind of a more significant form of concussion, as you know, the Glasgow Coma Scale, which is a measure of, let's say, how conscious you are at the time right after your, the fall or blow to the head or anything, can be a little bit lower than what we'd expect in concussion. The loss of consciousness in mild traumatic brain injury is usually less than 30 minutes. People can have post-traumatic amnesia, but this is usually of less than 24 hours. And there could be change in mental status at the time of the accident. That means confusion or disorientation, and it's very transient. The concussion and mild traumatic brain injury are different than moderate or severe brain injury, where here we see a change in the brain. We see that there's bruising or contusion, or there's tearing, laceration, or bleeding. And so the focus here will be on concussion or mild traumatic brain injury. And concussion is really an acute brain injury. So this is something happens to the brain or to a part of the body where the impact is felt on the brain. So it's mechanical injury or blunt impact to the head or other part of the body. And it can result in acceleration, deceleration, or rotational forces. And the trauma doesn't necessarily need to be to the head. It can be from whiplash or other parts of the body. And it usually results in this immediate or temporary alteration of mental functioning. And really, it's a very, very common problem. And, we think of it as a growing epidemic. We see it from sports, obviously, that's what, gets the most attention, but it can happen in the military, from falls, from abuse, many different causes. In terms of how many happen, we actually have no idea, because most people don't go get checked out for their concussions. Many people never even seek medical attention, but the estimated is around 750,000 concussions per year. But more recently, it was found to be that in 1 year, there were 150,000 concussions in Ontario in 1 year. And these had, interacted with the medical system in some way. And so obviously this 750,000 across North America must be an underestimate. And it's a clinical diagnosis. I can't stress this enough. There are no diagnostic tests for concussion. There's no imaging test for concussion. I know a lot of people get sent for SPECT scans. SPECT scans cannot diagnose a concussion. The tests that have been put out there, have received some media attention, were these two tests that are actually tests of more severe brain injury. So can't be used to exclude a concussion, but they can be used to exclude more severe head injury. Concussion is really a heterogeneous diagnosis and a heterogeneous population of patients. And so really no two people suffer the same injury after a head injury. And so it's sometimes difficult because the constellation of symptoms can be very different. As I said, even an MRI, which is very sensitive, cannot show any abnormalities in concussion, but we do occasionally find some evidence of a bleed. And this doesn't actually mean that your concussion is worse. It's something that we have noted now because, more routinely we are getting MRIs, whereas in the past people would only get CT scans, and that only showed us there was a more severe head injury. Having a little bit of blood in the brain after a concussion doesn't necessarily mean that you're worse off. We sometimes find these things what we call incidentally. In terms of the symptoms, they are very variable. There are constellation of symptoms that belong to the cognitive domain, like difficulty thinking, confusion, slowness of thinking, difficulty remembering, inability to concentrate. There are some that, pertain to personality or mood changes, like you could be irritable or depressed or anxious, become more emotional, sleep more, sleep less. And then there are the physical symptoms, post-traumatic headache and tinnitus, blurred vision, dizziness, sensitivity to light or sound, balance problems, fatigue, nausea. So you can see that there's a huge array of different symptoms. And recovery, luckily, happens in 85 to 90% of people, usually within 2 weeks in adults and 4 weeks in children. Neuropsychological assessments usually find people go back to within 5 days. And, we see a diffuse injury, so no focal neurological deficits in cranial nerves or motor or sensory exams. But there's a good number of people, and, based on the large number of people suffering from concussions, that don't necessarily get better in the 10 to 14 days. It used to be that the guidelines said, you had to have symptoms for 3 months. Now we've moved that, at 1 month. We call this persisting symptoms of concussion. It doesn't really presume an underlying cause. So we really have moved towards focusing on symptoms regardless of the cause. In terms of the number of people, again, difficult to know, but we'd say at least 10% of people do not recover from mild traumatic brain injury within 3 months. It's a very heterogeneous concept. And, when you think about it, 10 to 15% experiencing prolonged symptoms out of 150,000, that's a lot of people enduring prolonged symptoms per year. In terms of the persisting symptoms, well, they're actually the same types of symptoms that you see after a concussion. And so they can be physical, cognitive, psychiatric, behavioral. So sometimes symptoms start right away. sometimes they take some time to develop. And so, we see in more prolonged cases, more, let's say, agitation or aggression, whereas, early on, we might not see that. Post-traumatic stress disorder as well is something that develops later on, not at the time of the concussion. But again, large variety of symptoms. And what's important to remember is that, in concussion, there's this vicious cycle. There's an injury that happens to the brain. And after that, you develop these symptoms, and they're cognitive symptoms. They're what we call somatic symptoms. So I've already said sleep and pain and headache and dizziness, mood symptoms like depression, anxiety. And the problem is that these symptoms make other things worse, like cognition. And so if you have physical symptoms, they'll make your mood worse, but they'll make your cognition worse. If you have mood symptoms, they'll make your cognition worse, make your pain or sleep worse. And so it really is important to try to address each of these symptoms, no matter what the underlying cause is, as they can make your cognition worse. I want to focus a little bit on the neuropsychiatric symptoms, because these are very, very common, and many times people don't appreciate how common these symptoms are. The prevalence of psychiatric symptoms in persisting symptoms of concussion is extremely high. Depression in 14 to 61% across studies, anxiety from 18 to 60%. More concussions, higher risk. And of course, you can have more than one psychiatric disorder. Post-traumatic stress disorder symptoms can overlap concussion symptoms. Of course, you can have comorbid conditions like substance abuse. And, if you had a psychiatric problem before a concussion, then obviously a concussion can make it worse. What are risk factors for persisting symptoms? This is growing literature, and I have to tell you that it's an area of intensive research, as there's no consensus across what makes what puts people at higher risk for persisting symptoms. But what we kind of agree on, a history of prior concussion seems to put people at higher risk of persisting symptoms. Younger age seems to be associated with slower recovery, but I'll tell you that there are some studies that have shown older ages. Women, women seem to be at higher risk of concussion, as well as persisting symptoms of concussion. Mood disorders, so some evidence that previous anxiety and depression can predispose to persistent symptoms. Not everybody has found this. And previous headache, there's some evidence that premorbid migraine sufferers may be also at risk of more persisting symptoms, but you can kind of think that the likelihood of getting a post-traumatic headache when you already have headache, might be intuitively fairly high. Again, the literature is not at consensus for this. We often think of medical factors, though, that could exacerbate a problem. And so that means that, when a person gets a concussion, they get it on the landscape of themselves, right? We all have a background, we all have medical issues, we all have psychological issues, we all have, other factors like, stressors, financial, all kinds of things. And these can, be associated with more persistent symptoms. So like I said, history in terms of medical factors, history of previous traumatic brain injury, history of previous physical limitations, neurological or psychiatric problems, skull fractures, early onset of pain, and in particular headache, other health issues, obviously, anxiety. The number of symptoms seems to be a factor that people are considering. Now, none of this is, written in stone, but these are kinds of, things that we think of as red flags that make us think that we really need to be more proactive about people's treatments. Contextual factors. So these are the personal, psychosocial, environmental factors that can be associated with more persistent symptoms. And so, an injury in a motor vehicle accident seems to be associated with persistent symptoms. Litigation and compensation seem to be associated with persistent symptoms. Not returning to work or significant delays in returning to work seems to be associated with persisting symptoms. Being a student, life stressors, higher levels of symptom reporting, is associated with mood symptoms and heightened self-awareness of deficits. Older age, lack of social supports, lower education, lower social economic status, female gender, lower resilience, returning to a contact or risk of contact sport activity. These are factors that can be associated with more persistent symptoms. And why should we care? Prolonged symptoms are non-specific. There's factors other than concussion that can lead to concussion-like symptoms. And such factors could be related to the initial concussive event, but they could predate or follow it. These are associated with the diagnostic challenges of concussion. And, symptoms that are secondary to concussion could include psychological sequelae of a traumatic experience, such as depression or anxiety, pain sequelae, including headache, things, orthopedic injuries or whiplash and other injuries. And of course, there's the medication side effects that can also lead to concussion-like symptoms. So I often tell people, when you think of your brain, think of these gears in your brain, and they're all, working nicely together, and a concussion happens and, kind of stops the gears from moving. And, when we can, target headache or fatigue or, mood, we can get the gears going again. And even though we're not working on cognitive, we're not working on concentration per se or memory, we can actually, by helping the other symptoms, get those gears going again. And, maybe they're a little slower in the beginning, but eventually, helping one aspect of, or one, symptom can help the other symptoms and overall improve a person's outcome. And so what are the treatments? We treat the symptoms. Antidepressants are important for mood, whether it's depression or anxiety, cognitive behavioral therapy, goal management therapy. It's very important to treat people's headaches. It's so often I see people who are engaged in all this physiotherapy, but they can't really participate properly because they have terrible headaches. There's many different medications that we can use to prevent headaches. Sleep apnea is a huge problem. Poor sleep is very common. There's so many people who have sleep apnea, it's untreated. On top of that, concussion becomes a risk factor for weight gain, and weight gain is a risk factor for sleep apnea. So it's really important to have sleep assessed. And, there are different things we can try for sleep. I, personally think melatonin is a good remedy for difficulty getting to sleep. Vestibular physiotherapy for balance, low impact exercise, lots of evidence that low impact aerobic exercise is good for the brain and good for recovery. And then modified return to work, school, or play. Again, good evidence that returning to your pre-concussion activities is good for the brain. Neuropsychiatric treatment is very important. There's evidence for exercise. And so again, really important, I can't stress this enough, that aerobic exercise, low impact aerobic exercise is really important. And that, it's important, it's got evidence in the psychiatric symptoms, got evidence in sleep, and as well in persisting symptoms of concussion. So these delayed effects of concussion is a whole other category. So, people think about concussion and then they think of the persisting symptoms of concussion. But a few years ago, mild traumatic brain injury made it to the list of modifiable risk factors for dementia. So I often see people who, had a concussion a long time ago or had many concussions in their lives and, ask, well, am I at risk now for dementia? So, these large studies have indicated that, having a concussion can put you at risk of dementia, not what type, but, as a category. Now, you have to consider the fact that, head injury is amongst other factors. So things like physical inactivity, smoking, excessive alcohol consumption. Maybe you've seen the recent guidelines that are really promoting restriction of alcohol to very low levels, as it is associated with many deleterious health effects. Air pollution, infrequent social contact, obesity, depression, diabetes, high blood pressure, less education. So you can see, and hearing impairment. So you can see that that head injury is amongst a family of different risk factors. And so it's really important for us to obviously try to avoid head injuries and repeated head injuries, but they happen. But what I think is really important is to look at the other factors that that are risk factors. And so really try to work on the ones that you do have control over. We do have control over physical activity. We do have control over smoking and alcohol consumption and, obesity, making sure we don't, our diabetes is well controlled, making sure our high blood pressure is well controlled. So we actually do have a lot of control over many of these risk factors, even if, we've have had a head injury. And a risk factor does not mean that you will get this. It's one amongst many risk factors. The one that people think about the most in terms of degeneration is this chronic traumatic encephalopathy, which we really have only seen in former professional contact sports athletes who've had, repeated concussions, and some of them even subconcussive blows. I mean, some of these sports, they're just, they're hitting their head over time, many times, daily and over years. Seems to evolve slowly, and the symptoms seem to appear years after the injury. It was first described in boxers, but now it's been observed in hockey, football, other sports like military, motor vehicle accidents, and there are a few case reports for abuse. The symptoms, they overlap a lot of the, concussion symptoms, but are much more extreme. So in the psychiatric, which is a, prominent feature of this condition is, emotional lability and impulse control and aggression, then significant mood disturbance, and cognitive, well, obviously all cognitive domains, and then, eventually dementia. And then they also are described to have some motor problems. The challenge, of course, is, we cannot detect CTE in vivo right now. The symptoms that people have in CTE overlap, concussion, overlap persisting symptoms of concussion, they overlap many neurodegenerative diseases. So it's very hard when I have a 60, 70-year-old person in front of me who's saying, well, I have, these symptoms and I used to play this sport, or I've had many concussions. Like some people say, well, I had 5 car accidents when I was younger. Is that the cause? Hard to know. I'd say CTE right now is really only been described in professional contact sports athletes, and the factor of head injury in dementia is not a linear relationship where, you have the head injury, for sure you will get dementia. We're very far from that. So to summarize, concussions are the result of brain trauma. Symptoms are very varied and include memory problems, concentration, headache, dizziness, sleep issues, psychiatric. The persisting symptoms can occur, and there are risk factors for persisting symptoms, and to consider those. As medical professionals, we try to think about those when we have a patient, just because we'd like to know, when to intervene, in what ways, and we really, really need to treat the persisting symptoms while we look for a cure. And thank you. I will stop sharing.
Great, thanks so much. That was excellent. Just a reminder to everyone that you can enter your questions into the Q&A icon that you should see at the bottom of the page. And I also just wanted to let you know, when you click on the chat box, Christian has very kindly, he has put a PDF of Dr. Tartaglia's talk, and also the link to where you can find all of our previous videos. So those are available in the chat box. So let's go to the questions. So We have one from Michelle, and she says, I went to see and I think it's neuropsychologist today, who told me that concussions are not a brain injury and there is nothing that can be done to improve cognitive symptoms, such as number and letter flipping, memory issues, and word finding issues. Said that because brain imaging was negative, that meant there was no damage. Is there anything that can be done to improve the symptoms? I've had 25 concussions.
Yeah, that's a great question. So I'm not sure who this person is, but I guess we'll agree to disagree. So, when I think of a concussion, I think of, and try to figure out, well, where's the injury? Where's, the problem coming from? You can see that a lot of the symptoms that people have after concussion, so like headache or dizziness or, mood problems or thinking problems, they come from the brain. So we do feel that there is some brain injury there, even if it's, below the threshold. And we can't see it on MRI, which, I think is a good thing. It means it's not a big injury, but does not mean there is no injury. In terms of what people can do, there are many things people can do. There is a lot of evidence that exercise and, using the brain is good for the brain. So of course, in the first 24 to 48 hours, we tell people to, rest. But then afterwards, we want them to engage, as much as possible. We obviously don't want people to do an activity and end up in bed for like 2 days because they have a massive headache and they feel nauseous. But you can start with like some walking. You can start with and build up from that to having more aerobic exercise. In terms of brain function, I always tell people, it's important to keep your brain engaged. Like when you think of like summer vacation when you were a kid, right? The first few days you went back to school and it was so difficult to pay attention, to sit in class all day because, you weren't used to that anymore. I was talking to a teacher who teaches grade 2 and 3, and she was telling me that the kids are so unused to being in class, especially after COVID. She's having trouble at the end of the day. All the teachers are complaining. Some kids are even falling asleep because, they're used to being at home and they could do things at their own level. So it's important to think of your brain like a muscle and to use it. Even if you say, okay, well, you know what, today I'm going to read for a little bit, or I'm going to learn something today and I'm going to pay attention. And as you get better, to pay attention for longer and longer periods of time. So that, I know you were asking about specific things like memory and those kinds of things. Well, you can try to learn a new language and that tests your memory. And it could be things like Duolingo, which is free, and it's, learn a few words every day. But I think it's important to use the brain and definitely engage in some physical activity.
Great, thank you. We have another question. And this person is asking what the implication is of not getting access to treatment due to the COVID lockdown. I had my slip and fall just before the lockdown and wasn't able to get access to physio, et cetera, or get in the long line to access concussion programs like the one I was able to get into in the fall of 2021.
Yeah, I mean, we always encourage, people, and that's why I talked about, the risk factors. We're moving more towards trying to identify risk factors, but it doesn't change the fact that your potential for recovery is still there. And so, even if you start in a more delayed fashion, that's okay. You can, start with some aerobic exercise. If you haven't been doing for a prolonged period of time, then I think the main difference is that there might be an element of deconditioning there, right? So you would have to take that into consideration and start very slowly. And so maybe you would just do some walking. And then, in terms of how long it took in terms of your cognitive function, if you're off for a long period of time and not really being able to engage very much, especially with COVID, everybody feels that our way of working has completely changed. So you want to kind of reintroduce those things that you did before, whether it was going to school or going to work or being at home, introducing those activities little by little. But there's nothing about, delayed treatment that will, say, put you in the category of, yes, you won't be able to recover. No, I don't think so. I see people sometimes who are years out and haven't had many of their symptoms addressed, and we still manage to get them better.
Great, thank you. We have another question. My neuropsychological exam came back normal, but I still have cognition issues and cannot perform my work anymore, working as an attorney. Is this normal? The doctor that I saw said I have nothing wrong with cognition because the neuro exam was normal. I'm now 3 years out from my concussion and still can't perform the work I used to. I've tried many times to work again throughout this time, but wasn't successful. Any suggestions?
Yeah, so, I mean, neuropsychological testing, there's two ways to think about it. It didn't know you before your concussion, right? So you are the best judge of yourself, but I think you should be reassured by the fact that they weren't able to detect a significant problem. And so I usually tell people that I see in this case to, maybe identify certain parts of your work that you are able to do, and start back doing that. Or if you can't, because if you're a lawyer, I mean, maybe there's some legal issues in terms of going back to work, then doing activities that are kind of as demanding. So, take a course, engage in maybe consultation with somebody else, but trying to identify the things you can and build on that. I have patients of mine who are, physicians who, feel like, well, how could I go back to work? I used to run, this department, and if I make the wrong decision, people could, yes, but there are certain aspects of their job that they can do. And then they can go back, as observers, in partner with other people. So we always try to find a way for them to get back as much as possible.
Great, thank you. Karen asks, can repeated head injury, and she says, example, farmer kicked by cows, cause loss of color vision?
I don't know whether it would cause only loss of color vision. Of course, getting kicked in the head can damage nerves, especially if they're fractures. But I'm not sure it would only cause loss of color vision, and it would have to be bilateral, right? Like that's how you see colors. So no, I'm not really sure about that one.
Okay, thank you. Marilyn asks, any evidence for cholinesterase inhibitors in TBI?
Yeah, people have tried them. So cholinesterase inhibitors, for people who don't know, are medications that we use in Alzheimer's disease. And actually, the evidence is for when there is Alzheimer's disease pathology, that's when we should be using them. Now, the thing about traumatic brain injury is that, a person with traumatic brain injury who gets to a certain age, well, they could have Alzheimer's disease in the brain. So then in that case, I would say yes. But for, somebody who's 20 years old, who has had a traumatic brain injury, I'm not sure. There have been some small case reports of it, not very conclusive. I'm not sure. Cholinesterase inhibitors do have side effects. One is they slow your heart rate. They can cause diarrhea and cramps. So without proven efficacy, I'm not sure I would try them.
Okay, thanks. Catherine is asking where to go for help. GPs don't seem to have a good handle on the range of persistent symptoms or what to do. Neurologists take 4 years to see. I'm left to try to sort it all out alone.
Yeah, so I hear this a lot. Now, the thing is that, so some GPs actually do have a good handle. We have, there's some GPs who actually attend these webinars. There's some GPs who attend this echo concussion that is done weekly, which are basically a teaching for health professionals on concussion. So there are many more resources. There are some family doctors, I agree, don't really know that much about concussion, but that is changing. And so I would urge you to not give up. The second thing is that, when people think about the persisting symptoms, I usually say, well, maybe what's important is to focus on the symptoms individually. So family doctors might not know, or your family doctor might not be so aware of how to treat concussion related symptoms, but maybe they can treat headache, they can treat mood, they can send you for, an ear, nose, throat doctor. So, when we take a targeted approach, assessing your sleep, making sure that that's good. Sometimes we actually get very far, and family doctors are pretty good with all those symptoms. But when it falls under the persisting symptoms of concussion, all of a sudden it's kind of like a different beast. But that's not the way we think about it, and I don't think that's the way we should think about it.
Great, thank you. Monica, thanks you for your presentation. She missed the first few minutes. My apologies if this was addressed. Should one be pushing for a CT or MRI after a concussion, given the limited access at this time in the hospital environment? And if yes, what evidence can we point to support that request?
Yeah, that's a great question. And if you get the printout, like the PDF, you'll see CT and MRI cannot diagnose concussion. In most cases, we don't see anything. And so I don't think that, they're absolutely necessary. I have to say that, because I see patients sometimes who are years out from their concussion, I do get one. But I have to say that in the hundreds that I've gotten, I have none that have had any significant finding, except for in some older people where I find like white matter hyperintensities, like other things that it's like they should be paying attention to unrelated to their concussion. So these incidental findings that, I think are important, but for concussion, no. And now SPECT scans, which are often used, are not diagnostic of concussion, and more recently actually were thrown out of court, because you can have an abnormal SPECT scan for depression, a headache, some of the medications that we take, degenerative diseases, so cannot diagnose a concussion with a SPECT scan.
Okay, great. And just as a follow-up to that, someone is asking, saying, I assess many people with concussions who report persistent cognitive symptoms. Sometimes they have MRI scans, and on occasion, there are findings of non-specific white matter changes. Are these non-specific changes associated with cognitive deficits, or is this a completely non-contributory factor for their cognitive symptoms?
That is a great question. And, we're trying to understand that. So the problem with these white matter hyperintensities that we see on these MRIs is that they're very non-specific. So in, the right context, like an older person who has some high blood pressure and cholesterol and diabetes, we say these are all related to ischemic damage. In younger people, especially women who have migraines, we say, we see this in women who have migraines. And so they're very non-specific, and it's hard to know what to make of them if you don't understand the context. I tell you that when I see older people and I see lots of white matter disease, or even when it's mild, I do pay a closer attention to their blood pressures, and I make sure that all their vascular risk factors are taken care of, because I do think that the MRI can sometimes alert us that something is going on, that people, a lot of times people will have these borderline findings, right? Well, I have borderline diabetes, I have borderline high blood pressure. And meanwhile, their brain is being injured, and it's a silent injury also that they don't know about. And in those cases, I take it as an opportunity to try to treat the vascular risk factors unrelated to the concussion.
Great, thank you. Monica's asking, are we still asking youth and adults to avoid screen time in the first few days post-concussion, knowing how dependent most are on their phones' screen time for communication and connection with others?
Yeah, I think that's a great question. And I usually tell people, you are the best judge of yourself. So if looking at a screen gives you a headache or makes your headache much worse, probably limit. If it doesn't do anything, then there's no reason to. This is symptomatic treatment, right? Like having people rest from a screen is symptomatic. It's not disease modifying in any way. So I usually let people be the best judge for themselves. But if they tell me that, after a few minutes of looking at their screens, they get, their headaches get worse and they can't think and they're, they have concentration problems, say, well, you know what, limit the amount of screen time that you have.
Okay, great. Joseph says, I was struck by a car while walking at an intersection 3 years ago. I have numerous symptoms, both physical and cognitive. I'm concerned about dizziness spikes recently. For example, getting up from chiro or massage tables causes me to almost faint or lose my balance. Why is this happening? I have been diagnosed with vertigo, fibro, back issues, etc.
Yeah, so one thing is vertigo, and the other one is, like blood pressure problems. So vertigo will cause balance problems, and vertigo comes about when people have inner ear problems, usually, but an ear, nose, throat can try to work that out to see where the problem is. There are different canals in our inner ears, and some of them actually can be amenable to vestibular physiotherapy. This is completely different to somebody who's got blood pressure dropping. So people's blood pressure can drop for different reasons, usually unrelated to concussion. So I would be having that investigated, making sure that some of the medications you're taking aren't causing your blood pressure to drop, and making sure that something isn't going on that isn't necessarily related to a concussion, but could be quite serious, because obviously fainting is not good.
Great, thank you. Is it common to still be experiencing symptoms even after 2 years? This is my third concussion in 5 years.
Yeah, I mean, there's two answers to that. So the first is that, yeah, you're actually in a 10 to 15% of people having persisting symptoms, and they can be upwards of a few years. I think the other thing to think about, though, is, have your symptoms actually been addressed? Are they persisting because they're persisting after many treatments, or are they persisting because they actually haven't been addressed? I see many people who've had headaches for 2 years, almost daily, and they come to me because they can't remember, and their concentration is poor and their mood is poor. And I'm like, well, somebody who has a constant headache for 2 years is not going to feel that great and is not going to be able to remember that much, and obviously will be like upset and irritable and maybe not sleep well, which make all those symptoms worse. And so it's very important to think about this vicious cycle, how some symptoms are actually making other symptoms worse, and to try to address them. So there's one thing for somebody who's actually failed all treatments and does truly have persisting symptoms. But a lot of the times, I tell you, people do have symptoms that are amenable to treatment, and the treatments haven't been used. I see people who take Tylenol every single day or Advil every single day. If you do that, you will have medication overuse headaches on top of your regular headache from post-traumatic headache. And you usually end up with some gut problem and, poor sleep and all kinds of things. So yeah, I think it's important to really address and target the symptoms.
Great, thank you. Stacy says, I'm 5 years in, I was crushed by a moose, and I think is saying she had a C1 fracture. I have constant headaches. I have constant facial pain. On gabapentin, 900 milligrams 3 times a day for nerve damage. When I'm late on my meds, my face aches more, reddens and swells, will feel like I've just been punched. Is this a good dose? Is there something else that would make me feel better? Or is there something I can do to quicken the healing of this nerve damage?
Yeah, that's a very unfortunate accident. And yeah, moose accidents are terrible and can be quite tragic. The dose you're taking of gabapentin is fine. And, although it's a higher dose, it is still within the acceptable range. And actually we sometimes use 3,600, even 4,800. So you do have room to go up. in terms of, but that is only if your kidneys are okay, you know, and other things are fine. You know, we don't have medications to help deal with nerve damage. And it does sound like, unfortunately, you have had nerve damage from this injury. Gabapentin is good. Some people like, you know, the other one is called Lyrica or pregabalin. It's similar to gabapentin. Some of the antidepressants like duloxetine also work on nerve, you know, can help with nerve pain or a headache. But you know, gabapentin is a good choice. And if it's helping, which it sounds like it is, because when you're late, you actually notice. Yeah, unfortunately, it's slow to recover from nerve damage.
Okay, thank you. Jen has a client with a concussion sustained in a motor vehicle accident about 9 months ago, has visual motion sensitivity, headaches, and nausea. Has tried to emphasize low-level activity, but he's ADHD, which is not new, and has many difficulties staying within his limits. Recently, he has started with a specialist for the visual motion issues. This and some stress has absolutely tanked his progress to the point where he is worse than he has ever been. Is it warranted to withdraw all treatments and suggest a break?
Yeah, I think, you know, well, I would say it's probably warranted to stop some treatments that actually may not be helpful and making him feel worse. But I don't think we should stop all treatments. Like when I'm talking about treatments, I'm talking about treating mood and treating sleep and treating pain. I don't know about this visual motion sensitivity. When people have headaches, they cannot do these vision therapies that actually have very little or no evidence for them. And many times will get much worse. I have patients who didn't even complain about vision problems, are sent for vision therapy, but have terrible headaches every day, and they get nauseous and actually vomit. And I think, well, how does this even happen? It's like, in my mind, it's like I was complaining about, you know, a hand pain, and somebody put my foot in a cast and said, well, let's treat that foot. And it's like, well, wait a minute. I didn't even have a foot problem. I have a hand problem, and it's not getting better. And so I really tell people you need to be critical of the treatments that you're embarking on, because, you know, in some cases they're only causing poverty, but in other cases they're actually contributing to making you feel unwell. So no, I do not think we should stop all therapies, but we should stop the ones that aren't helping him get better.
Okay, great. Thank you. Colleen asks, I know someone who has had a lot of falls due to epileptic seizures. Not sure if there were actually concussions. Do you assume concussion after multiple seizures and falls?
Yeah, that's a great question. And I do see some patients in my clinic who have had concussions after seizures. Actually, they don't always have a concussion after a seizure, but sometimes it happens. And so, you know, I have patients who've had many seizures in their lives and only suffered a concussion after 1 or 2 or 3 of them. But of course, some people can have repeated concussions because of that. And yes, we do treat them as post-concussive on top of their other, you know, their other problems.
Great, thank you. Heather asked, does it matter where you hit your head?
It doesn't seem to, you know, people really focus on that. It's like, well, my headache is here and, you know, I hit my head there, but then it spreads to the other side. So the only reason I actually pay a little bit of attention to it is because sometimes people have very, very focal. They say, my headache is right here and only there. And then I say, okay, well, you know what, maybe that's like you ended up with some damage to an occipital nerve. But when it's like starts in one place and spreads, or it's always on one side, well, a lot of headaches are like that. Even primary headaches are oftentimes only on one side, or one part of the brain, not the brain, the head. So, you know, I don't spend that much time thinking about where it is. But if it's, very, very focal, and I think, oh, maybe that's a target for therapy, yes, in that case, I do take it into consideration. But otherwise, no, I don't.
Okay, great. From someone else, I'm almost 9 months into recovery following my fourth concussion. Unfortunately, I have had exacerbations of symptoms from light taps to the head on multiple occasions during this time frame. So, for example, bumping my head just lightly on a shelf. Are there recommendations for treatment to help minimize these exacerbations with these occurrences?
Yeah, that's a great question. And we hear that a lot. It does seem that, every concussion a person has decreases their level for getting concussed, but also sometimes just for kind of like reemergence of their symptoms. And so, I had one person tell me that he felt his concussion symptoms when his children would, jump on his lap, and they were little. So it wasn't, that they were being like super aggressive or violent. So the fact that the symptoms emerge don't mean that you're having a concussion. And that's why we say, we have to think about the symptoms, not necessarily the underlying cause. I really focus on trying to control the symptoms as much as possible. So make sure that if, the symptoms include headache, that, if you're a few months out, that you start on some medication to prevent headaches and not, always just running after the headache. It really depends on what the symptom is. But we think that treating the symptoms will decrease this likelihood of, having emergence or reemergence of symptoms on with light injuries that in previous years would have never caused you any symptoms at all.
Okay, thank you. How important is a formal return to work? I think this is supposed to read in returning you to pre-concussion capabilities.
I think it's really important to have a plan in place for return to work, a graduated return to work plan. And as soon as, feasible, right? Like, obviously if you've had like terrible, facial injuries and all these other things, you have to get over some of those things. But, I often say, okay, let's, we're going to try to deal with like the headaches. We're going to try to deal with like the dizziness and those things. But, within a few weeks, we would hope to start a plan. And sometimes there cannot be a formal plan because it's like, I can only stand doing something for 15 minutes or 20 minutes. And, your workplace says, no, you have to start at least with like 2 hours or 4 hours. And so I say, okay, you can take an online course, you can volunteer in a library, you can do things that kind of replicate what you're going to have to do at work. And then the formal, plan is important because obviously you cannot go from 0 to 100 in one day if you've been off for a few months, and so it is really important to have some kind of like graduated return where your chance of success is much higher. And so that could include, going for a few hours every other day or a few hours a day. It really depends on the job that we have.
Great, thank you. Here's a question, a quick one. When you say old person, I think this is when you were talking about older individuals versus younger individuals. What age do you mean?
Yeah. And so, to be old nowadays, you really have to be like 85 and older. But older in terms of concussions and being, more exposed to, the aging effect. We usually think of, above 60, 65, we think of as older.
Okay, thank you. Karen's asking, I think has a teen who had post-concussion syndrome, seems to have recovered. They're back at school. He's been running distances for gym, then has difficulty focusing on his next class, which is math. Could this be related to the concussion?
It's hard to tell. It really depends on how far out the person is. And, the thing is, well, do they have trouble focusing on other subjects too? Is it only that one, is it only that one class that follows them running? Maybe they have to try running with another class, it would be kind of odd if they've recovered. And the running, because the running itself can sometimes re-evoke symptoms, but not the concentration. What they'll notice is, sometimes they get nauseous or can, feel a little dizzy or their headache. But I'm not sure it's related to concentrating in math.
Okay. What are the first steps to be taken on the field when a player suffers a concussion?
Well, take them off the field and probably, making sure that they don't have a more serious injury than concussion, making sure that they don't have a whiplash injury that needs to be taken care of, that they don't have a, more severe brain injury that needs to be taken care of. I mean, whiplash, not just whiplash, like a spinal cord injury. So those are the first things. Make sure the person is safe and doesn't have any other medical issues. And then really, making sure that they get assessed properly and don't return until they are, perfectly fine. The one big concern we have is that somebody suffer a concussion while their brain is still healing. The worst case scenario is something like second impact syndrome. And, you probably all have heard of Rowan's Law, a young girl who died because she had a number of concussions over a few days and her brain was swollen. So that's the worst case scenario. But the other scenarios are really that the chance of persisting symptoms while your brain is trying to heal from one concussion and you get another one is actually really, really high. And that these symptoms persist for extended periods of time, also very, very high. So avoid that.
Okay, great. When treating a patient with moderate to severe concussion greater than a year post-injury, should the patient be cutting back on physio sessions for balance or vestibular therapy if they're still experiencing nausea, vomiting, headaches on a frequent basis?
So I'm not a physiotherapist, but I really think that a person who's getting 1 year of physio after a concussion probably needs to have this reevaluated. To me, that's way too long. And so I think that, one, I would say reevaluate the symptoms that are being addressed, reevaluate the person, seeing, okay, if they're getting vestibular physiotherapy and it's 1 year out and they're still not better, it's important to look at, okay, has the right canal been addressed? Is this a different type of problem? As something else developed? What are we addressing after 1 year of these therapies? And it's like when you take a medication, you give people medications, right? You should be always reevaluating the need for that medication and making sure that the person still needs that and that things have not changed. So I say the same thing for physio, for all these kinds of allied health therapies. They need to be reevaluated because they take up a person's time, they're taking up their energy, and so they really have to be beneficial.
Great, thank you. Okay, I'm just conscious of the time. I think we'll do one more question. From your experience, what strategies help people engage with technology without aggravating symptoms?
Yeah, that's a great question, but it really depends on the types of technology. So usually I tell people to use, these like these kind of orangey screen filters. I think it's called Flux. It's a free online app. Change their phones to like the night mode. Sometimes people wear these blue glasses. Those things, if it's real screen sensitivity. I would say those are the things that I've tried the most, and then limits. So a lot of times people will say, well, I can do 15 minutes and then I get a headache. Okay, well then do 15 minutes and take an hour off and go back to it, and kind of like pace yourself and stagger it and separate it out during the day.
Great. Okay. Thank you so much, Dr. Tartaglia. It was a great talk, and thank you to everyone out there for all of your great questions. I'm sorry that we couldn't get to all of them. There's still lots more, but just having scanned them, I will say that we do have all of our previous webinars archived. They're on the Canadian Concussion Center website. And if you look at those, you'll see that generally they follow different, the more common symptoms that some of you are asking about. So you can find more information there. And then we also have new webinars coming up as well. So on that note, our next one is going to be Tuesday, October the 11th, same time. And we're going to have Dr. Mark Bailey, who's going to be talking to us about exercise therapy and concussion. And finally, just you'll know that if you've been here before, we're going to send you just a short survey. We'd love to get your feedback. Any comments, suggestions that you have for us are much appreciated. So have a good evening.
Good night. Thank you.
Night.